Welcome everybody. Good morning. We're so excited to have you join us today. This is the sixth presentation in a series of six supported by the Connecticut DPH and the Overdose to Action Grant. The previous presentations can be found on the CT Comprehensive Pain Center website. For ease of transmittal, I'm going to go ahead and shut my camera off. We just don't want to lag in the slides today. We'll turn our cameras back on at the end for questions. So today, all four of the CCPC team will be speaking to you today. Myself, Jennifer Ozimek, and Rebecca Andrews, the two primary care physicians with specialty expertise in pain management, and Dr. Kevin Chamberlin, our PhD of pharmacy, and Surita Rao, our psychiatrist with special focus in addiction medicine. And today's topic is Teamwork Makes the Dream Work, Office-Based Policies and Procedures for a Team-Based Approach to Pain Management. Next slide. Our learning objectives for today's lecture are to describe a policy and process for a consistent approach to controlled substance prescribing and practice, identify optimal components of a medication use agreement and monitoring process, and understand how to utilize members of the team to promote safe prescribing. Next slide. This is a helpful infographic from the CDC, and really it's just well established that opioids are a high-risk medication. The higher the MME, the increased risk of overdose and death. And this really highlights the importance of having office policies and procedures in place that help optimize our ability to safely prescribe these medications. Next slide. This is another image from the CDC, which highlights that as many as 1 in 4 patients on long-term opioid therapy in the primary care setting struggle with opioid use disorder. There have been 165,000 deaths since 1999 from overdose related to prescription opioids. More than 40 people die each day from overdoses involving prescription opioids, and 4.3 million Americans engaged in non-medical use of prescription opioids in the last month. And these numbers should really all highlight the importance of safe prescribing. We are going to review office-based practices that help us minimize misuse of medications we prescribe to hopefully drive down these statistics. And one more infographic just from the Connecticut DPH. This is from 2015 to 2021. And this is actually the drug overdose death dashboard that you can see it's updated regularly. You can see from these numbers that it's still a rising problem in Connecticut with an increase in unintentional drug overdose deaths. And the bottom box on the bottom right shows the drugs involved, with the dark green being fentanyl and all of those in the yellow section being different prescription medications such as tramadol, methadone, oxycodone, to name the top 3. Next slide. So in light of the increase in overdose and death, the legislature has implemented policies to help us target this growing problem. Increasing access to opioid antagonists, enacting Good Samaritan laws, establishing a statewide prescription monitoring program, and establishing a 7-day limit on certain opioid drug prescriptions. I'll pass it over to Dr. Chamberlin to go over some of these policies in greater detail.
Thank you, Dr. Ozimek. So since 2011, Connecticut has passed many laws related to opioids and naloxone. So first, in 2011, the goal was to encourage people to call 911 when an overdose occurred. This was the act concerning emergency medical assistance for persons experiencing an overdose and the designation of certain synthetic stimulants as controlled substances. The law states the person can't be arrested for possession of drugs or drug paraphernalia, and the law does not protect at this point the person from any arrest for any other cause, including outstanding warrants. That's to come later. In 2012 was PA 12159, an act concerning treatment for a drug overdose. And this law allowed medical professionals who are allowed to prescribe medications to prescribe naloxone to any person. The prescriber themselves was protected from civil liability and criminal prosecution, but the person administering the naloxone was still not protected until 2014. So in 2014 was the Good Samaritan law, essentially. This is the person administering the naloxone to someone who overdoses is protected at this point from civil liability and criminal prosecution. Follow that in 2015, Connecticut pharmacists who successfully complete training can become certified to prescribe and dispense naloxone to customers who request it. Department of Consumer Protection is responsible for this program. They maintain a list of certified pharmacists and pharmacies, and it enhanced the access to naloxone. This same legislation also requires prescribers to check the CT prescription monitoring and reporting system, or CPMRS, if they want to prescribe more than a 72-hour supply of a controlled substance. In 2016, and now on the bottom row of the timeline, we had the Act concerning opioids and access to overdose reversal drugs. This law set a 7-day limit on opioid prescribing, but still left room for exceptions which must be documented in the patient's medical record. Next, in 2017, was Public Act 131. This law covered a number of topics, so I'll try to summarize it. Essentially, it further lowered the limit of opioid prescribing from 7 to 5 days, specifically for minors. As with 2016-43, prescribers now could prescribe opioids for more than 5 days for minors as long as they document as required in the patient's medical record. Another feature of this legislation was that the prescriber must explain to the patient the reason an opioid is being prescribed, the risks associated with it, and also required electronic transmission of controlled substance prescriptions direct to pharmacies. The last two, so 2018, PA 166, this was the law that allows agreements between prescribers and organizations, permitting organizations to train and or distribute naloxone, further enhancing access. And lastly, in 2019, was an act addressing opioid abuse. This one has a number of interesting requirements. So substance use disorder treatment programs must provide training and naloxone prescriptions for naloxone to their clients and training for their clients' friends and family as they wish. Colleges and universities must have policies on naloxone posted directly on their websites. People can't be denied life insurance for receiving a prescription for naloxone. Persons prescribed opioids for pain for 12 weeks or more must have documentation in their medical record. There needs to be an agreement or a plan that includes risks, the need for urine drug screening that would cause the prescription to be discontinued, and options for treatment pain other than opioids. And lastly, hospitals and EMS systems will report overdoses to the Department of Public Health, and that data will be shared with local health departments. Dr. Rao?
Thank you. We'll talk a little bit about destigmatization of office procedures for patients. So many patients have strong reactions of shame, suspicion, irritability, or even anger when such procedures like urine toxicology screens or pill counts are requested. There are even patients who refuse naloxone because of the stigma. It is very important to introduce and frame these procedures as universal procedures that are being applied to all patients in the practice who are receiving prescriptions for any controlled medications. Handouts that can be given to every patient at the time of their initial appointment or during a change in office procedures can be very helpful in this regard. You could even script your front office staff to tell the patients that this is a universal procedure, it is being given out to everybody, and they are not being singled out in any way. Another technique is to frame urine toxicology as a lab test, which it is, similar to monitoring blood glucose for patients with diabetes or liver function tests for patients receiving statin medications for heart disease, or even such as taking blood pressure measurements. Next slide, please. It's important through all of this to be respectful to the patient at all times, but also to be assertive, clear, and calm, and not to get into the weeds of discussions of or arguments about the procedures. So the current period of heightened attention towards mitigating opioid-related risks can be termed as opioid pharmacovigilance. And this is a term that encompasses the fact that federal and state government agencies, national professional associations, healthcare institutions, and individual physicians, nurse practitioners, and practices are putting in various procedures and protocols to try and minimize opioid misuse, psychological dependence on opioids, diversion, and development of substance use disorders. In a study that I found online, there were a lot of patients interviewed who reported their own feelings when being asked to participate in these procedures. Overwhelmingly, the feelings were negative and shame-based. They reported being perceived as a quote junkie unquote or an addict or as being described as quote drug seeking unquote in both the clinical contexts and at pharmacies. And in the case of urine toxicology screenings, many patients expected this monitoring, but then had a variety of reactions to it. Some felt negatively about the monitoring interventions right away, with one participant stating, quote, I felt like I was a prisoner being tested for drugs, unquote. Other people started out with a more positive, accepting attitude, thinking of it as a way to prove their commitment to treatment, but then it progressed to where they began to feel that it was accusatory. One patient said, quote, that I was being judged for potentially using drugs that weren't prescribed to me or using them inappropriately. That made me feel a little less understood, unquote. We can think about these emotional reactions as an unconscious absorption of societal prejudice towards people with substance use disorders that the patients have internalized. I will now pass it along to Dr. Jennifer Ozimek.
Thank you very much, Dr. Rao. So I'm going to go over the components of our office policy, and these components encompass a lot of those legal requirements that Dr. Chamberlin was going through, and as well as cover the best practices to help promote safe prescribing. We're going to review medication agreement with SMART goals, the use of urine toxicology, the importance of office visits every 3 months, how to review the CT-PMRS every 90 days, the use of an opioid risk tool scoring system. And throughout all of this, as Dr. Rao was just talking about, we're going to stress the importance of destigmatization for our patients. Next slide. So the medication agreement, first as an overview, the data behind medication agreements is really not to prevent diversion, although setting rules up is important. We hope that medications agreements do prevent diversion, but there's just not great data out there to support that. Really, the most important piece of the medication agreement is this functional goal setting, and it serves as a guide when to stop therapy, when it's not appropriate anymore because of this risk-benefit balance. And the medication agreement also should serve to foster a shared decision-making model. It helps us provide a continual review of risks and benefits and work together with the patient. Next slide. So some downsides of the medication agreement and some potential criticisms. This study was done over 10 years ago. It found physicians felt the medication agreement was serving them some sort of legal protection, which is really not the point of the agreement. It's not a contract. You'll hear me refer to this again and again as an agreement. And that's because this is not a legal document. It's not legally binding. And many physicians felt that because this medication quote unquote contract was in place, they could then take liberties with the other requirements, such as not doing a UTOX, stating because I have the contract in place, I don't necessarily need to do all the other stuff. And in general, the thoughts on this survey suggested that physicians were using these agreements like contracts to provide them legal protection and take away any blame on the physician rather than using a patient-centered approach. Next slide. Some other criticisms, some people have argued that it could damage the patient relationship. It may send the message, I don't trust you. And this is where I think using it appropriately and effectively is important. Stigmatization, it may be written above the patient's education level. It may make patients feel like criminals. Sometimes patients feel they may have a lack of choice. It's seen as paternalistic, like you must sign this. There's a level of coercion there. Patients may feel that violation of the agreement could lead to abandonment. And then there's questions of lack of efficacy. And I really think most of those come from a lack of great studies out there rather than it really not being effective. But our goal is to teach you how to appropriately use these agreements to avoid these pitfalls. This is just one example how patients may view it. So there's this whole website out there on Very Well Mind, and there's other ones, that you can see that are really warning patients how to advocate for yourself before signing this agreement. And this just shows you how stigmatizing it really can be for patients to have to sign these when it's not handled properly. So what are the benefits? This was a meta-analysis looking at studies on medication agreements that found some of the benefits include fostering an open conversation, supporting patient autonomy and shared decision-making, and most physicians reported relatively little time to actually complete these, so it didn't take that long. The meta-analysis still found some negative use of the word contract within some of the studies, which can foster a feeling of imbalance of trust. Patients feel like they may have to sign. However, despite these potential downsides, all of which really come from an inappropriate operationalization of the agreements, not the agreements themselves, the use of medication agreements is part of the guidelines for chronic pain therapy with level 3 evidence. Next slide. In another review that looked at 4 studies with comparison groups, found that opioid misuse was modestly reduced anywhere from 7% to 23% after treatment agreements, with or without urine drug testing. And a separate review found the proportion of patients with opioid misuse after treatment agreements, urine drug testing, or both varied, down from 3% all the way down to 43%. Next slide. So let's take a look at our medication agreement. It starts with an informed consent section, which goes over all of the risks of opioid use, which, as you probably remember from Dr. Chamberlin's discussion, this is actually part of the legal requirements. We need to review with patients the risks, the possible risks of these medications. And this is a helpful section because it demonstrates for people that we care. We care about them, their safety, and our job is to protect our patients first and foremost. Next slide. This is the next section. It goes over possible benefits. It's important because this really demonstrates for our patients. This is a balance of risks and benefits at all times. Next slide. Alternatives. This is an important component as well. Consider and reminding providers and patients to think about what other adjunctive treatments that they may be using or maybe they haven't considered yet and should consider at this point. Next slide. And then this is the section that you fill out together. So after you review those prior sections, you get to this part, and we'll spend some more time in a minute on the treatment goal. But here you identify a reason for treatment. This is actually very important, particularly for the inherited patient who may not be able to verbalize exactly what they're taking the pain medication for. Sometimes they've been on it so long, they forgot almost why it was initially prescribed. So clarifying what they're taking it for, that helps the provider think about to make sure they're using the best modality for that mechanism of pain. And then a functional goal. And so we'll define this in a few minutes. How do we think about a treatment goal for the patient? And then defining what their prescription is. And this last section is really important because we want to avoid patients running out early, saying they weren't clear on their regimen, requesting early refills. And so making sure the patient really understands how they are supposed to take their medication. Next slide. And then this is the section where they sign. And see, it says in bold, medication agreement. Throughout all of this policy, we avoid the word contract, and we really encourage you all, when sharing these with your patients, to really avoid the use of that word contract. So this is an agreement, something that you're going through together with the patient. Next slide. So how do we come up with that agreement goal? We recommend using SMART goals. SMART goals are specific, measurable, attainable, relevant, and time-based. And these are some examples that we've seen as we've done chart reviews on these patients. Some examples of quote unquote bad goals. And I have bad in quotes here because obviously these goals are not bad, but they're just not as specific as we would hope them to be. So increase activity, that's quite vague. Kept pain under control till they fixed my body. Also vague, although getting a little bit more specific. And the last one, allow patient to be more active in order to help with weight reduction. That's really getting there towards what could be a SMART goal, but we would really encourage that patient to be a bit more specific. How are they going to get more active? Is it going to be walking 20 minutes a day? How much weight will they lose? Is it going to be 5 pounds? Over what time? Over the next few months? So an example of a better SMART goal would be use my opioid medication so I'm able to play on the floor with my grandchildren 4 times per week for 30-minute stretches over the next 2 months. If we wanted to improve that third goal above, we could say, for example, walk 20 minutes per day while completing physical therapy and lose 10 pounds by the next 3-month follow-up, for example. By making our goals more specific, we can really hold patients to these goals and make sure that we're continually following that balance of benefit versus risk. So moving on past medication agreements, the next part of our procedure we're going to go through is urine toxicology screening. So this is recommendation number 10 from the CDC guideline for prescribing opioids for chronic pain. And the CDC suggests that this should be done at least annually. We'll argue for a little bit more frequently, and I'll show you some of the data behind that, but at UConn, we recommend every 6 months. And it's important, as Dr. Rao was mentioning, discuss with the patient, this will be done. This is a part of a lab test, just like I would monitor your A1C, and have expectation setting. It's always going to be easier to discuss with the patient the possible outcomes of the urine toxicology before it's ordered, rather than having that conversation for the first time once the result is coming back. Next slide. So this was a study that looked at urine toxicology in long-term opioid therapy, and it reviewed 500 patients. It found that 8% of the patients were found to have inappropriate findings on their UTOX. 1% tested negative for the medication that they were being prescribed, which is concerning for possible diversion, and 12% tested positive for illicit substances. Repeating the urine toxicology screening over time in this cohort found that 63% had improved compliance over time. Next slide. This is another study that looked at the overall frequency of these inappropriate findings in the urine toxicology. And it found that 22.4% in this study had at least one inconsistent UTOX finding. And 2.8% of all urine tests at any given time were inconsistent. So this would require 36 months to detect a single aberrancy. And semi-annual testing would require as long as 216 months to detect aberrancy. So this study really supports that urine toxicology does work. However, the more frequently we do it, the more likely we are to pick up the abnormal findings. And so that's why at UConn, we recommend going beyond the CDC recommendation of annually to 6 months, but really you could argue that even every 3 months would be potentially appropriate as well. Next slide. These are some helpful tips from the CDC to help destigmatize the UTOX and focus on patient safety. Do not jump to conclusions with unexpected results, have candid conversations, and focus on the result rather than labeling the patient. We want to focus on objectivity and the findings. And this is where having these conversations with the patient before you even order the test can be incredibly helpful. Next slide. This is just a helpful reference regarding the window of detection, and you certainly don't need to become an expert in this. It's easily available to look up this information, but it's helpful to know if a patient comes back and says, oh, well, I did cocaine 2 weeks ago before we started on the medication agreement, understanding that cocaine is likely going to be out of the urine at longest by 4 days. So just kind of understanding the timeline can be helpful, and we want you all to be aware that this information is readily available. Next slide. And this is how we can categorize some of the possible outcomes of the urine toxicology. An illicit substance may be there. A non-prescribed drug may be there, for example, a benzodiazepine for a patient who's not on a prescribed benzodiazepine. Or the prescription drug may be absent, which is a concern for diversion, and in rare cases could be seen with a rapid metabolizer. Next slide. So we've gone over the medication agreements and urine toxicology. The next thing I wanted to mention is just office visits every 3 months. The CDC recommends that clinicians should evaluate the risks and benefits at least every 3 months for chronic pain patients. And this really helps us get through our checklist. Having them come in for a visit makes sure that we are checking off each of these components. And we recommend including this checklist at the end of each visit. Just like we see our hypertensive patient who's uncontrolled every 3 months or our diabetic patient every 3 months, thinking about this like a chronic disease management is really important. And we can even use this checklist as part of the rooming process as well. So we encourage you to have your medical assistant check on when their last UTOX was. They could grab that as they're rooming the patient, and really working as a team to get all of these things on our checklist completed. And now I'm going to pass it back over to Dr. Rao.
So we're going to discuss the opioid risk tool. The opioid risk tool, ORT, was developed by Webster and Webster in 2005 as a brief clinician-administered self-report screening tool designed for use with adult patients in primary care settings to assess the risk for opioid abuse among individuals prescribed opioids for treatment of chronic pain. So it's kind of a mouthful, but basically it's a tool just like we use the PHQ-9 for depression to just screen to see who might be at risk for developing opioid use disorder, and it does not diagnose opioid use disorder. Again, it is very important to emphasize to patients that this tool is being used universally for all patients receiving an opioid prescription, and body language of the clinician is important. So taking a minute to check in with yourself is helpful and calm yourself down if you feel anxiety approaching the patient with this tool. Patients categorized at high risk are at increased likelihood of future abusive drug-related behavior, but it is not a given. And the ORT can be administered and scored in less than 1 minute and has been validated in both male and female patients, but not in non-pain populations. The tool should be administered to patients upon an initial visit prior to beginning opioid therapy for pain management. A score of 3 or lower indicates a low risk for future opioid abuse. A score of 4 to 7 indicates moderate risk, and a score of 8 or higher increases a high risk for the patient abusing their opioids. Next slide, please. So this is the opioid risk tool itself. As you can see, it is very simple, and it basically falls into some categories, which make scientific sense. So the family history of substance abuse or substance use disorders is because there's a strong genetic component to the development of substance use disorders. Genetics is not destiny, but it is a very important factor. So family history of alcohol abuse, illegal drugs, and prescribed drugs. Then a next section is a personal history of substance abuse. Again, substance use disorders are lifetime illnesses. People go into recovery but not get cured, just like you would think of it for breast cancer, or somebody who's had a myocardial infarction. They cannot go back to being the person they were before because their brain has changed, but they could have very good quality of life and never use anything that is addictive again. So that's why the next section, patient's own history of abusing alcohol, illegal drugs, or prescribed drugs. Age between 16 to 45 years, and a history of pre-adolescent sexual abuse in women, because studies have established that sexual abuse in childhood is a huge predictor for women developing substance use disorders in the future. A large percentage of women who suffer from substance use disorders have a childhood history of sexual abuse. And then finally, the existence of ongoing psychiatric or psychological disease in a patient, such as attention deficit disorder, obsessive compulsive disorder, bipolar disorder, schizophrenia, or depression. Next slide, please. So in a large study that studied 1,178 patients, in this study, the discriminant predictability of the ORT was evaluated in a unique cohort of patients with chronic non-malignant pain who were taking long-term opioids, prescribed opioids, on long-term opioid therapy, who displayed no evidence of developing an opioid use disorder, and then a sample of patients with chronic non-malignant pain who developed an opioid use disorder after commencing opioid therapy. This was a secondary analysis of baseline data, as I mentioned, collected from 1,178 patients. It was a cross-sectional naturalistic study designed to create a phenotypic and genotypic profile of patients' risk factors for the development of opioid use disorder when receiving long-term opioid therapy for chronic non-malignant pain. And what it showed is that the opioid risk tool was able to discriminate between patients with and without opioid use disorders. When the pre-adolescent sexual abuse item for women was removed, the opioid risk tool had similar results. and an unweighted opioid risk tool without the sexual abuse item was actually superior. Next slide, please.
Thank you, Dr. Rao.
Thank you.
So we thought for completeness, we would go back and go over some aspects, including things that we use commonly, but the CPMRS hasn't been around forever for everyone. And so I think understanding kind of where it came from and the history behind it's important. So the purpose of the CPMRS is to present a complete picture of a patient's controlled substance use, including prescriptions by other providers and prescribers, so that the prescriber before them can properly manage the patient's treatment, including the referral of a patient to services offering treatment for drug abuse or addiction when appropriate. The Connecticut State Legislature passed a law in 2007 that requires information about all transactions for controlled substances, Schedules 2 through 5, dispensed in Connecticut to be or under a Connecticut license to be reported to the State Department of Consumer Protection Monitoring Program. Data submission from over 700 pharmacies dispensing controlled substances both in Connecticut and another 400 out-of-state mail order and internet pharmacies are included. Updates have consistently been made to the system, providing prescribers and pharmacists more and more information. So on the left, with your standard Schedules 2 through 5 medications being included, the system now also includes information on things like medical marijuana and some non-controlled medications that could also have abuse potential, such as gabapentin, which is known for causing euphoria. We know some limitations still exist, and so one would be methadone. The methadone dispensary information under federal law protection, aka once daily methadone maintenance, is not reported. Only methadone dispensing information when used for pain from a traditional pharmacy is maintained and included in the report. On the right side of the screen shows common medications and illicit substances abused in Connecticut per a report by the Connecticut Consumer Protection. Designer drugs such as bath salts or K2 or spice, which are synthetic cannabis, or bath salts like cathinones, also known as Molly on the street, have similar effects to amphetamines and cocaine with hallucinogenic effects. The more the system is utilized, the more powerful a tool it becomes. And so prescribers and pharmacists can build out their patient dashboards to enhance efficiencies in searches. And now even many EHRs are building the information directly into their systems with subsidized funding from both federal and state governments. With any search database, remember that actually less is more. Patients can use aliases, secondary addresses, or cross state lines, and you need to think like a patient in some of this regard, unfortunately. Interstate data sharing became one of the newest upgrades to the CPMRS. And authorized roles in the CPMRS currently have access to prescription data from approximately 40 states, including Washington, D.C., Puerto Rico, and the military health system. This includes all border states for the state of Connecticut. Further, Connecticut allows other states to connect via the PMP Interconnect or PMPI system, which is data sharing hubs that use end-to-end encryption to facilitate data sharing across state borders. Patients with similar names, dates of birth, or addresses will prompt a pop-up for you to cross-check and verify. Probably one of the most recent enhancements is the inclusion of a scoring system mechanism as seen here on your screen. What are called NARCS scores are designed to draw awareness to the presence of significant PMP data. They represent information at a glance and are best used when incorporated into clinical workflow, such as an automated result. Some important considerations and understandings when using NARCS scores. First, NARCS scores that raise concerns should trigger a discussion, not a decision. NARCS scores are not abuse scores. It is true that at very high scores, patients are likely to exhibit some form of misuse in their PMP record. But a score alone cannot be used to determine appropriateness or misuse. The number of prescriptions, prescribers, and pharmacies used all influence this score. The narcotic and sedative score overlap in that in the PMP's own explanation, narcotics, quote unquote, contribute to the sedative score and vice versa. So as a result, a patient may have a low narcotic score even though they haven't been prescribed a narcotic. And lastly, overlapping prescriptions are heavily weighted in the scoring algorithm. The key requirement is that two different prescribers prescribe the same type of medication for use on the same day. And so the higher the score, the higher the suspected risk to the patient. The concurrent high-risk meds visual is an easy tool to quickly scan timing of meds and risk over time and appears just beneath the NARC scores in the report. But the crux of the report is the RX data itself, as seen here. Here we look for trends such as an early refill, multiple prescribers, multiple pharmacies, or cash payments for prescriptions when insurance is otherwise used. Again, remember that methadone will only appear on this report when it's prescribed for pain in a traditional pharmacy. And in the bottom part of the report, while mostly grayed out here for the purpose of protecting information from the example, realize that the power of all the contact info for prescribers and dispensing pharmacies can be efficiently enabled or used to enhance communications.
So I'm going to show you how you can put this all together in your office. It will go over some of the components that Dr. Ozimek already talked about, but we wanted you to see it in its completion. So our medication agreement is contained within our chronic opioid therapy toolkit, and there are a host of components to this, including this welcome letter that really discusses our commitment to safe pain treatment, that we will try to use additional medications also included in the toolkit, and then alternative therapies, not just medications, for a multimodal approach, and that we will monitor for adverse effects with the patients, again, highlighting their safety. So our toolbox puts this all together. The components, just to list it out for you right here, are the welcome letter to kind of set the stage with what our expectations are, but our reasoning, our office policy, the medication agreement, alternative therapies, how and when to use naloxone and where to order it, and then instructions on actually how to use this. And included, of course, is the opioid risk tool that Dr. Rao spoke of earlier. Our policy really lays out the steps for use of chronic opioids for non-malignant pain and the necessary components of the policy, either because of the state law or institutional reasoning, as Dr. Chamberlin mentioned earlier. It really provides an opportunity for us to educate all of the prescribers so they feel like they have a good handle on the state law and they are not at risk themselves by failing to follow those laws. This also includes the need to check the state-controlled substance database at least every 3 months if you're prescribing long-term opioid therapy. So for staff, office, physician, and other clinician training, you can use this policy in this toolkit. The first step really is to remove that stigma. Make sure everyone understands that the goal of agreements and policies surrounding controlled substances is all about safety of patients. In the literature, sometime between 10 to 12 weeks of prescribing is when you convert to chronic or long-term opioid prescribing. And at this point, we need to really focus on improvement of function and reduction of risk. So we chose 3 months as the cutoff ourselves, and after that point, we expect the prescriber and the patient to go through the medication agreement that Dr. Ozimek spoke about, setting that functional, not pain level based, but functional based goal, such as being able to work a full shift at their job, and then really reviewing the risk assessment for the risk of addiction or misuse. Patients deserve the right to know before making the decision to continue the medication. And then, of course, reasons we stop prescribing. Everybody likes to focus on, I guess the more negative reasons such as selling and diverting or using illicit substances while we prescribe. But there's also more important, like return on investment, and is the risk worth the benefit, such as people who are having falls, not reaching their functional goal, or serious side effects such as urinary retention. There are other risks that are really important to talk about with patients, such as gonadal suppression or hyperalgesia, that people don't always realize are a part of it. And then, of course, options to limit opioid side effects. You educate the patient and the prescriber on different NSAID classes, medications for neuropathic pain, etc. And as mentioned, we do at least every 6-month urine toxicology just to make sure that we are, again, looking at safety for the patient. So good clinical care means structured chronic pain visits with or without opioids, and the physician or other clinicians are provided this form to help them cover important components of a chronic pain visit. I know we spoke about this in the first couple of talks. There, about 66% of physicians in practice do not feel comfortable with pain. So we also have it in the form of a checklist that is easy to review. Some people might find when you're in the room with a patient that it's actually easy to go through this with them so they can see how standardized it is.
Thank you, Dr. Andrews. So now I'm going to go through a case with you all. We hope that by going through this brief case, you can see how we utilize the checklist in our clinic visits. So this is a 75-year-old woman, history of bilateral knee OA, hypertension, CKD, who's been on long-term opioid therapy with oxycodone 5 milligrams twice a day for her knee pain for as long as she can remember. She's tried steroid injections with no improvement and was deemed not to be a surgical candidate because of her BMI. She presents to establish care and transfer all of her care to UConn. She's seen for her new patient visit and then asked to return in 4 weeks for a dedicated chronic pain visit. And notice we don't prescribe at the first visit. We're having her come back so we can do a comprehensive visit just focused on her pain. Next slide. So for her first pain visit, we're going to first obtain a clear HPI regarding her pain. We want to get all the 7 parameters, figure out what's going on with this pain on a day-to-day basis. How is it impacting her daily life? Together, we want to come up with her treatment goal. And the patient decides that her treatment goal will be to take pain medication so I can complete my ADLs, including getting dressed, as well as light housework and grocery shopping each week, while I complete a course of physical therapy for my knees over the next 8 weeks. And this is because through the HPI, we come to learn that the patient has really not done physical therapy for her knees in many, many years. So we define her regimen as part of the medication agreement. She's going to take the oxycodone 5 milligrams BID PRN, as well as Tylenol. It turns out she really hadn't been taking any Tylenol, so we're going to add that back in, 1,000 milligrams 3 times a day, scheduled. And she previously did not tolerate gabapentin due to sedation and cannot tolerate NSAIDs due to her CKD and uncontrolled hypertension. Next slide. So this is sort of our checklist at this first visit for her chronic pain. We're taking a multidisciplinary approach. A PT referral is placed. We considered our adjunctive medications. We're going to be using Tylenol in this case. We log in during the visit and check the CT-PMP before writing our script. We order her urine toxicology and review to the patient why we're doing this, what we expect to find. We complete the medication agreement together, including her SMART goal, which she has defined. We discuss Narcan and send over a script for that as well. We review constipation, and we advise her on her way out to book a 3-month follow-up for her chronic pain. And now I'll turn it back to Dr. Rao.
So now we discuss the offended patient, which refers back to my slides earlier in the presentation, stigma and prejudice. Stigma is a powerful social process that is characterized by labeling, stereotyping, and separation, and it leads to status loss and discrimination, and it all occurs in the context of power. It's important for us to think about these things because we have to sometimes place ourselves in the shoes of the person who's suffering from the stigma. And stigma is brought to bear on individuals or groups, both for health, which is disease specific, and non-health, like poverty, gender identity, migrant status, sexual orientation, various differences that could be real or perceived. A national study of 976 people from the general population that was published in 2021 demonstrated that people are more likely to agree with statements that describe opioid use disorder as a medical condition. And this may represent a changing belief among the population as a result of media depictions and the government's education program about opioid epidemic. So this actually helps us in our clinical practices. However, stigma, conscious and unconscious, against people with any type of substance use disorder persists among patients and healthcare workers. And as I mentioned before, this is reflective of the larger population. The offended patient. So, as I said before, take a minute to check in with yourself internally and calm your emotions and connect with the more intellect-driven, logical side of your brain. Allow the patient to fully express their concerns before allaying their anxieties. This is true for any intervention in life. If you have an anxious person in front of you, whether it's a coworker, friend, family member, child, allowing them to speak fully about their anxieties before presenting solutions works better to lower their anxieties. Remind the patient again that the procedures are universal and that you're not diagnosing them with substance use disorder or tagging them in any way as somebody who's at risk for developing opioid misuse, unless, of course, they do meet those criteria and the opioid risk. And give them an example of something outside of healthcare, like all airline passengers go through scans and baggage checks and security. Be respectful, professional, assertive, and calm, but it's very important not to be apologetic. Next slide, please.
Okay, so one of the reasons that we have been so dedicated to this series is that we really want to remove the stigma surrounding chronic pain. So we can start having a conversation about what is the best way to treat patients without judgment. Getting the whole team involved really sends that message very effectively because it's no longer a power struggle between a choice the doctor makes and a patient's pain, but rather a normal office process, like ordering an A1C for a patient with diabetes or a vaccine for someone who needs one. Obtaining a urine sample can become the same as asking for one when a patient has symptoms of a bladder infection, rather than doing something that produces the feeling that you are, criminalized. The best part is you are no longer alone, but a team. So all of a sudden your MA may let you know that the patient had a lot of difficulty walking to the room secondary to their pain, or maybe even that they lost their medication and were afraid to mention it. So treatment by the whole team, that collaboration is really felt by the patients. And the benefits of interdisciplinary care teams has been well studied. A team approach allows for bias recognition, it improves critical thinking, highlights ethical concerns that you might not highlight on your own, and provides discussion and room to mitigate those ethical concerns. It also helps us accommodate ambiguity better. If we are all together on the I'm not 100% sure this is the right diagnosis for the moment, but we're going to try it. We're going to see if this pain approach works. It's more comfortable because you have multiple people who all feel this is the best path. And then last, honestly, who wouldn't want to have nursing, pharmacy, social work on a daily basis for all your patients? We would all flock to the model because we know that each member of the team has an area of expertise that they bring to the table. So here all of our examples of how we've also included IT with the medical professional team working together. So we embedded our opioid toolkit into Epic. That is a resource that the clinicians can just drop down from the top. We have MME or morphine milligram equivalent calculations that are right in the chart. We have order sets that limit initial prescriptions of controlled substances for safety, as well as order sets that are actually panels so that we can be sure we order the right urine toxicology. So not just the urine tox, but also the confirmatory testing to make sure what we're prescribing is being taken appropriately. We're working on integration of the state database for the controlled substance network without a second sign-on. That's not complete yet. And I'll show you a BPA, the best practice advisory or pop-up alert that comes up a little bit later. So for interdisciplinary learning, there's been a lot of recent advances in the learning sciences. Interdisciplinary teams allow for the fact that preconceived ideas or notions are just a fact. So you have that before entering a team discussion. Your ideas are formed from homes, culture, family, friends, experience, religion, etc. But we all walk into the team with both experience and implicit biases. In a team, if you develop trust, you can gain insight into those biases and overcome your belief framework, allowing you to re-examine the facts in front of you in a broader way. So you're basically tossing out the narrow viewing aperture you came into the group with for a much wider lens. All of this culminates in I'm just going to leave this up for a second. This is the recognizing bias, where we come in with our preconceived notions of what is, and then we drop that for really what truly is in front of us. So all this culminates in enhanced critical thinking. Trainees develop an appreciation of differences between disciplines on how to approach a problem, so it's always great to have learners with you, and this leads to a broader understanding of the issue under investigation. To be explicit, there are certain skills learned. You incorporate multiple alternative viewpoints, an ability to process both factual knowledge, but also applied knowledge, and then integrating the conflict that might arise if there's a difference in opinion on how you want to treat a particular patient. So in short, having all of the disciplines together, trying to understand the same or related problems, working together for the best approach to the patient with critical clinical analysis produces a clearer understanding of the problems, but also the capacity to integrate ideas that you as an individual would not have come up with yourself. I know I mentioned this before, but this is something that's really important. The ability to tolerate the unknown, especially with someone with chronic pain. We are probably not resolving a pain of 10 years, but we can treat it to the best of our ability. And there is some trial and error there, even working as a team. So instead of focusing on what is right or being right, we're actually working on what is the best treatment for the patient in front of us and acknowledging the complexity. It also really does allow for a conversation on ethical considerations. If you're worried that the patient is diverting or not using all the medication, how do we cut them down? And with a whole group, there's a support network for the person who's prescribing the medication. If you take as an example a patient who's always had an elevated A1C, maybe the physician has tried to work with a diet or a nutritionist, they've changed medications, encouraged exercise, educated, and maybe even lectured the patient a little bit. But it's when the pharmacist went in the room and discovered that there was a family member, in fact, a daughter, who had an injection drug use disorder, that we realized that the patient was afraid of the needles and really thought in their conceptual framework that by using insulin, they would be at risk for developing a drug use problem as well. And so we switched them to an insulin pump that did not require that for use. So how do you form effective teams? There are whole books written on this, but essentially you have to trust each other, be able to tolerate and work through conflict, be committed to the team, but also accountable for if you're bringing in a bias or being contrary. And then you have to have successful results for the positive momentum to move forward. Some of the reasons that you would want to use a policy or a medication agreement with the toolkit are because it really creates these concrete guide rails to use with patients. Everybody is aware of it. Everyone is trained on it. There are no specific patients you choose to deploy it on, and you really start to learn what are expected behaviors and tolerated behaviors and what is not so. You can return to the original signing of the medication agreement and that discussion that Dr. Ozimek talked about as a trust base point if you do have to stop the medication, so the patient understands that it's all with their best interest at heart. And then in the last couple of slides, I just want to put this up. Each team member has multiple roles. They can even cross over each other and they can share them. I wanted to put this up on here. This is our most recent initiation. It is a best practice advisory. Anyone who's prescribed over 50 MME a day will get a pop-up until they prescribe naloxone and send it to the pharmacy. This is something that we have struggled with, and it just goes to show you how you can use your electronic health record at your best disposal so that it can help you hit those best practice metrics. And just to remind you, there's really good evidence in the literature for this as well. So if you don't believe just us, there was an article that recently came out about using clinical pharmacy in a chronic pain clinic, and it just showed that between adherence to medication agreements, UTOX is performed, but also reducing the MME given, and the initiation of non-opioid medications, which were safer. All of those metrics were improved with the use of a robust team. This is just the last slide. I think that you've seen this before. As far as our toolkit goes, this is what we put in the end of each of our consults, just so the provider knows if there's anything that they are missing the mark on our checklist. I'll put this slide up for a second. This is just from trainees who have had the opportunity to experience what we do, and they have listed some comments here that they realize that well-intentioned physicians have made, the decisions that they make, that this process challenged them to think about patients in pain from multiple angles. Some comments about care quality. I'll be able to extrapolate this to my own patients, that it's methodically dissecting every aspect of pain, and I can take that to my own practice. And then finally, one of our main goals, which is being more comfortable with pain management.
And with that, again, a big thank you for the Connecticut Department of Public Health, who has made this conference possible over the last year and a half. You know, when we started this, who knew where we were going to be or where we would still be a year and a half later? So great, huge, big thanks to the DPH and the funding through Overdose Data to Action. And I think if we can have the panelists turn their cameras back on, we could then take any questions.
So if you post your questions to the Q&A, we should be able to see them. I don't see any right now. Kelly, do you have any that I'm missing?
I don't see any at the moment.
We'll give everyone a minute. Just from the aspect of the whole team, is there anything that you think we missed today that we didn't have a chance to go in depth about? I would say, since we have no questions, I'll just comment. There are times when the medication agreement, even as welcoming as we have tried to make it, has been difficult to use. It can be viewed as burdensome from the patient. So I think that's why we highlighted over and over that it was for the best practice and for the safety of the patient. I think more and more practices are going to some type of agreement. And I would just say the more explicit it is, everything from, do you do refills on nights and weekends? For instance, we do not. Giving the patient sort of those guide rails, when to call for refills, how to access your physician, who will cover if your physician is out of town, etc., are all really important.
I think, that's a great point, but I think a great way to revisit it, on a semi-regular basis is, hey, we want to revisit what your functional goal was. It's, 6 months later, it's 12 months later. Let's measure how we're doing against that goal. Is it still a reasonable goal that is accomplishable, or do we need to kind of tweak expectations?
I think the other good thing about that is you ensure that someone understands that these are still high-risk medications. And so if you're prescribing it for spinal stenosis, they're not to use it for knee pain because, they were moving furniture over the weekend. Dr. Ozimek, Dr. Rao, anything else to add before we sign off, since we have no questions?
Just about the naloxone. Recently, when I was seeing a patient with my resident who is on buprenorphine maintenance therapy for opioid use disorder and has been clean from all street drugs and alcohol for many years, the naloxone prescribing thing popped up on Epic. So we talked to her about it, and I was surprised at the level of discomfort she exhibited. She was very nice about it, but she seemed almost like to be surprised that we were prescribing this. So my resident framed it to her as, take this, this could be helpful for you to save somebody's life. And it's not necessarily for you, because when people are, accidentally overdosing, they may not be able to use their own naloxone. And I told her, give it to, or let your mother know that it's in your purse. So she kind of visibly relaxed when my resident, Dr. Ortegon, said, this might help you save somebody else's life.
Dr.
So it's
Rao,
important
that's such a great point. I don't want to cut you off, but we do have one question, so I just want to make sure we get to it just because it's 8:45.
Yeah, so I don't know beyond the panelists who's able to see it. So it says, have you experienced a shift in pharmacist perspective on the crisis? Pharmacists in my jurisdiction feel that pharmacists are regulated more than other areas. Overdose rates are increasing, but dispensing rates are dropping. How do you convince that audience to keep the work going? Yeah, I mean, I think it is really a call to arms across professions. It's not just from pharmacy, but I know that, in some aspects, pharmacists are as much on the front lines as prescribers themselves in clinic. And I think, I think that the cultural shock, this social stigmas still exist. I think there is a lot more concern and worry that surrounds prescription opioids, especially continued use. And as long as pharmacists continue to maintain that questioning attitude for the safety of patient outcomes, that our work will persevere and help.
Yeah, I would back that up 100%. Anyone that touches patient care, whether it is the person who checks in the patient, the physician, other clinicians, the nurses, the pharmacists, it doesn't matter. We are actually all in this together and we all have a responsibility. I think we know in Connecticut that overdoses aren't so simple as just watching prescribed medications. People who have opioid use disorder, for example, and maybe have managed to get that through prescription medications, when they turn to something on the street because we are being more cognizant and trying to get people treatment, someone might not be ready for treatment. And if they don't want to start methadone or Suboxone or go into a treatment program, they may then turn to something that's on the street. But that, and then have an overdose. But that does not mean that we are not all responsible, because we really are.
I'll leave it with one comment. Unfortunately, illicit substances that are on the street, and this is in the news and in the media everywhere. There is nothing pure anymore. There is something is cut into nearly everything that people are getting on the streets, and so I think that mindset, while we might be plateauing or decreasing dispensing rates of prescription opioids, that unfortunately the overdoses are continuing to rise. So I think with that, we're up against time. I would like to, give a great big thank you to my panelists and my clinic members that we've been working with together over the last year and a half. So thank you. Thanks, everyone. Be safe.
Thanks, everyone.